Welcome you all. Happy to welcome you all for the IPNA endorsed Webmaster Series 2020. We are spanning from September 12th to December 23rd. It's a pleasure in introducing our speakers. We have 3 speakers for the day. The session will be moderated by Dr. Shweta Priyadarshini. She is a senior consultant in pediatric nephrology at Apollo Hospital, Jubilee Hills, Hyderabad, and Butterfly Pediatric Specialty Clinic. And she is graduated from the prestigious University of Armed Forces Medical College, trained in pediatric nephrology and transplant immunology at Harvard Medical School, Boston, USA. She has a twin fellowship in IPNA and MGR University fellowship. Her research in transplant immunology at Harvard Medical School, USA. She is a member of ISN, IPNA, and IAP. She has got multiple publications to add on in national and international publications. She has contributed to a lot of chapters in multiple books. Over to Dr. Shweta.
Thank you, Dr. Kalaivani, for the kind introduction. So today we have got 2 eminent speakers, Dr. Sunil Shroff and Dr. Satya Prasad, who are going to speak on 2 topics, mainly the nocturnal enuresis and voiding dysfunction, its overview. I will be giving a brief introduction about the topic, and then I'll hand over the dais to the speakers. So, next slides. Where do we increase this? Okay. To introduce, urinary bladder is an important organ to maintain continence. It serves as a storage organ for urine that empties completely at specific intervals of time. Any alteration of its function leads to a wet child. To define, enuresis is defined by the International Children Continence Society as normal voiding that occurs at an inappropriate or socially unacceptable time or space. It leads to complete emptying of the bladder, and it should happen at least twice a month after 5 years of life to be called nocturnal enuresis. It needs to be differentiated from the terminologies incontinence and dribbling. So that's why I'll just touch upon a few definitions. So incontinence implies urinary leakage without emptying. Dionyl enuresis is wetting during the day. Nocturnal enuresis, wetting at night. Primary enuresis, the child has not been dry for a period longer than 6 months. And secondary enuresis, where the child has been dry for a period longer than 6 months, but has recently become enuretic again. So, little bit about the bladder function. Bladder functions by an interaction of autonomic and the somatic nervous system, as you know. At birth, the control of the bladder is from the sacral spinal cord, and hence the child is unable to see that he feels like voiding. At 1 year of age, the pontine voidic center matures, and the spinobulbospinal reflex pathway is established. By 2 years, child begins to tell about the sensation of fullness of bladder. By 2 to 4 years, he acquires voluntary control of bowel and bladder. And by more than 4 years of age, the adult type of voiding pattern is established. So bladder, as we know, has got 2 functions, filling and storage, and bladder emptying. The filling and storage is under the control of sympathetic nervous system. And the filling happens with increasing volumes at low pressures. The sensation within the bladder stays normal, and the bladder outlet, as you see here, is closed. The bladder emptying is under the control of parasympathetic system and the pudendal nerve, and coordinated contraction of the bladder smooth muscle with the lowering of the resistance at the sphincter leads to bladder emptying. So as we know, the bladder capacity is not same throughout. The bladder capacity increases with age. The normal bladder capacity for age less than 2 years is weight in kg into 7. For age more than 2 years is age in years plus 2 into 30. And the bladder and bowel control, they develop sequentially in a child. First, the child becomes bowel control develops by the night, then bowel control by the day, then bladder by the night, and bladder by the day, and then bladder by the night. Now, while reading about nocturnal enuresis, I came across this very interesting article in the Sage journals. So it's about a little bit about the historical perspective of nocturnal enuresis. The first reference to nocturnal enuresis can be seen, it has been documented in Eber's papyrus of 1550 BC by Pliny the Elder, who said that the treatment for nocturnal enuresis is boiled mice in food. In 18th century, mechanical and chemical stimulation as a treatment modality got established. Basically, they used vitriol for stimulation of the sacral area. In Victorian era, more modernistic approach developed, and people started practicing fluid restriction, enema, alarm clock, hot and cold baths, and galvanic stimulation. Now, this is one interesting thing. Tory in 1972 in Western Nigeria, he suggested tying of toad to the penis of anuretic boys. And when the child would pass urine in bed, the toad would croak. Now, this resembles the electric bell and pad system that we have today. Coming to voiding dysfunction, the International Children Continence Society describes children who habitually contract this urethral sphincter during voiding as dysfunctional voiders. This leads to reclusal sphincter dyssynergia, and the child is neurologically normal in this. Child does not have any neurological issues. So voiding disorder can be of both the phases, either of the phases. Filling phase disorder that leads to overactive bladder or detrusor instability, and it presents at all the lower urinary tract symptoms of urgency, frequency, and enuresis. Constipation worsens the bladder dysfunction in about 51% of the cases. Evacuation phase disorder, it leads to like interrupted voiding of urine, staccato voiding, bladder sphincter in coordination. And what you have to remember that long-stand dyssynergia leads to lazy bladder or underactive bladder and overflow incontinence. Just a slide on this dysfunctional elimination syndrome. Now, this term and dysfunctional voiding is used interchangeably. However, just to tell you, this term was coined by Stephen Koff, and he coined this term to emphasize association between severe idiopathic constipation, wetting, bladder instability, recurrent urinary tract infection, and recurrent urinary tract infection. Basically, the loaded colon presses on the bladder, proximity, and leads to lower urinary tract syndrome. With this, I would hand over the dais to the eminent speaker. Our first speaker for the day is Dr. Divya Satya Prasad. Dr. Divya Satya Prasad is an MD in pediatrics from Guntur Medical College, and he has IPNA fellowship from the prestigious All India Institute of Medical Sciences, New Delhi in 2006. He did clinical fellowship training in pediatric nephrology from National University of Singapore, and he is affiliated as lead consultant pediatric nephrologist in Rainbow Children's Hospital, Hyderabad. His areas of specific academic interests are renal vasculitis and intensive renal care. And he has presented many papers in national and international scientific conferences and conducted many workshops on CRRT and peritoneal dialysis in children. Over to Dr. Satya Prasad.
Thank you, Dr. Shweta. Thank you very much. I'd like to thank our organizing committee for giving me this opportunity. In this session, how to approach voiding dysfunction in children. Voiding dysfunction is a broad term to describe conditions where there is an inconsistent coordination within the urinary tract. It might be because of complete relaxation or overactivity of the cellular muscles during voiding. What are the objectives? First, you should know how the lower urinary tract works. Different voiding disorders we should define presentation modes, and we should evaluate properly so that we can give effective management. How lower urinary tract works? What are the options of lower urinary tract? Storage and emptying. Bladder should store adequate volumes of urine at low pressure without any leakage. Coming to emptying, emptying is an voluntary act, efficient and complete, so that bladder should empty completely at low pressures without any post-residual. The functional integrated unit of the usually comprises of vascular junction, bladder, sphincter, and urethra. All these under control of urology. The signals from brain should reach all things. For proper coordination, we should have control. Coming to anatomy and neurophysiology in the tract. Bladder.
Dr. Satya Prasad is having some technical issues at his end, or he is unable to come on air right now. So I'm inviting the next speaker, Dr. Sunil Shafsa, for the talk, today's talk. Dr. Sunil Shroff, we all know him. He's a senior consultant urology and transplantation at Madras Medical Mission Hospital, Chennai. He has got a huge CV for me to go through, but yes, the notable positions held by him is President-elect of Indian Society for Organ Transplant, President of Medicine Society of India, Tamil Nadu chapter, past President of Madras Urological Association, and many more. He has had many publications and research papers. He has edited 6 books on transplant law and urology for paramedical and nursing staff, published 12 book chapters, 620 articles in peer-reviewed journals, newsletters, newspapers, magazines, and on the web, and made 800 plus presentations. Original research on use of holmium, YAG laser in urology in 1992-94 at the Institute of Urology, London. He has also been a recipient of multiple awards in the last 10 years. And now, it's all there on the slide to see. He has had many awards, and we all know Dr. Sunil Shafsa. That's the whole reason why I said he really does not need any introduction. So now we'll move on over to Dr. Shroff.
Shweta, thank you very much, and thank you, Kalai, and International Pediatric Nephrology Association for inviting me this evening and to speak to you all. Am I audible?
Yeah, you're audible.
Am I audible?
You're very much audible, sir. You're audible.
So yeah, thank you. What the slides coming back again? Let me see. There are challenges, so we will do our best under the circumstances, and try and as quickly as possible as well, so that I can give you perhaps a good overview. And sometimes the god of internet, is not predictable. There it goes again. I think it keeps disappearing. I don't know why. The slides keep disappearing. So let me just give you a current understanding on nocturnal enuresis, and I'm going to give you a very practical approach on how we treat this condition in the clinics. So we run a bedwetting clinic again. Oh my God, what's going on? The slides keep jumping out. I don't know why. It could be either I am challenged with this technology. Can I get my slides back? Or Satya's slides are back. I think he's also a presenter and I'm also a presenter here.
maybe he's trying to get into the system. I'll just try to.
I just click on with your slides, sir.
But my slides are jumping, so I'm not able to see them. I can only see Dr. Satya's slides at the moment. I don't seem to be able to get my slides on. Let me see. So let me jump on this. Okay. So let me again start. We run a bedwetting and noxious clinic, and that is supported by Ferring Pharma with patient nutrition promotional material at Madras Mission. But there's no financial gain for me or my team with the support which they give us. So this is my declaration and my disclaimer. Why is Nocturnal Enuresis so important to recognize and intervene? This is a video, I don't know if it will play today. Let me just try. You know, last year, there was a child of 16 who committed suicide after he was, after his classmates found out that he does bedwetting, and he committed, he hung himself. So the psychological impact of bedwetting is huge. And that's the reason I think we need to take this condition rather seriously.
Okay.
Oh, God. Yeah, here we are. So Shweta has given an excellent introduction to the bladder, this control, and how as the child grows, the maturation of the nervous system, and there's good control. The control starts developing. At the age of about 2, they develop conscious sensation of bladder filling between age 1 and 2. And then between the age of 2 and 3, they develop ability to void or inhibit their voiding voluntarily. And by 3 to 4, they develop adult pattern of urinary control and dry during day and night. Of course, the parents, the mother has to help the child to train them into, when to evacuate, when not to. And that plays a very important role in their control. Again, Shweta did tell us about the bladder capacity in children. Am I audible, just to be sure?
Yes, sir.
Yes?
Yes,
Are you able to see my slides? Yes?
Able to see your slides, sir.
Thank you so much. Thank you. I'm sorry. I just want to be sure. So the cough formula is very popular with the pediatricians, I'm sure. I don't know how to tell you, but just to tell the trainees, perhaps, if they're watching, the bladder capacity in children, you look at the age and then you do +2, and then and that is in ounce, and 1 ounce is equal to 30 ml. It's a very simple formula. So, that's what you do. If you have a 5-year-old child, if you want to calculate the bladder capacity, then it will be 5 + 2, that is 5 is the age +2, it becomes 7 ounces of urine, which will be multiplied by 30, so it will be up 210 ml capacity. So simple. And this is again how much the child's capacity is and how much they void. Again, I don't need to tell the pediatricians; they know this better. As far as nocturnal enuresis is concerned, when you look at the parents' perspective, in a survey which was done, in 2005, 68% of parents said that their child's pediatrician or family doctor had never addressed the bedwetting during a routine visit, regardless of the child's age. But obviously, this is from abroad. I'm not talking about the Indian situation, but this is just a broad, survey. And I don't think so. It's very different here, because I've had patients whom I've asked, "What did your pediatrician tell you?" And I also have some similar impression that many times that is not very well addressed. And then also the parents are uncomfortable starting a dialogue with the physician, because they believe that bedwetting is not a physical condition and the child will come out of it. So it is not necessarily always the pediatricians, but always the parents also. And most parents believe the child bedwet because they are stressed or worried, or in some cases, they're simply lazy. So there is oh my God, okay, sorry. I don't know why this does that. Let me just go back. So, there is a World Bedwetting Day now, which is celebrated sometimes in May. And the theme is usually to, bring this awareness forward. And in 2019, it is not their fault sort of thing. As far as child's perspective is concerned, from that perspective, there is, inadequate treatment for bedwetting, and this has a lot of psychological, ramification, and they do have, it affects their emotional, social behavior, and this is well known as well. A physician's perspective, many physicians feel that they'll grow out of the problem, and the treatment can be deferred. And I'm so sorry, but the slides keep jumping, so I'm not able to control them as well as I should be doing. Let me just try and go back. Okay. So, and many family physicians and residents receive very limited training in bedwetting, because it's not necessarily in curriculum, So we did a survey in Chennai of 6 to 12 years, and there is Shweta, who is our physician assistant, and Sangeeta, who is a social worker, social activist, whose own children were having bedwetting. So they both joined and did this last survey. And this was a survey form with some simple questions which we asked. And, we did a survey of 1,277 children in 3 schools in Chennai. And we had 8%, prevalence of bedwetting in children. And as the international also, the same story we had here also, majority of them, 64% were boys, and half were girls in the bedwetting group. And if you see the age group of our survey, you see that at the age of 6, 29% had bedwetting, and even at the age of 11, almost, the age of 10, 11% were having bedwetting. And the frequency of bedwetting per week was also looked at. And if you see that, almost many of them had almost daily bedwetting, And if you look at the international study as well, and you'll see something similar, but, same thing, the bedwetting affects boys more than girls. And, the rate of, it resolves spontaneously at a rate of about 15% a year. And by the time they cross the age of 15, the prevalence is less than 1%. So definition of bedwetting, again, I think Shweta did mention this. It is involuntary discharge of urine at night by children who are old enough to be expected to have direct control. And bedwetting will be, if it persists after the age of 5 years, and, they are usually continent, are dry during the day. It is usually the night that they have the problem. So, that's why it's called, it's called nocturnal enuresis, and it's, it's called primary bedwetting or nocturnal enuresis when, the bladder has never been, control has not been attained, but it's called secondary bedwetting or nocturnal enuresis, where if the child has been dry for at least 6 months previously and again starts getting wet, then it becomes a secondary bedwetting. Also, depending on the symptoms they present, it can be monosymptomatic when it is associated with normal daytime urination. It can be polysymptomatic when it is associated with other symptoms. They may have daytime symptoms, they may have daytime bedwetting, they may have urgency, they may have frequency, and so on. And when you look at the cause of bedwetting, then there are 3 things you need to consider: their urine volume, their bladder contraction, and their sleep arousal. And we'll talk about these 3 as we go along. There is a genetic predisposition, and now we also have identified a gene. And it has seen that if one parent has bedwetting, then there are 44% chance of the child having, and if there are 2 parents, then majority of children, or almost 77%, may have bedwetting. And it is also seen that it is due to excess urine production because there is inadequate amount of response to ADH at night, it is seen. And also, as I said, there's arousal disorder because there is lack of awareness of full bladder during the sleep. So there is also could be somewhat diminished functional bladder capacity, slow development of bladder control. There is a slow maturation of the nervous system, and of course, emotional behavioral issue. It could affect, If the child has, ADHD, then this is a specific comorbid, condition, and it has been seen that in children who have ADHD, the nocturnal enuresis becomes a little bit more difficult to treat than other kids. It also, if you look at the circadian rhythm, where, the day and night kind of rhythm is, what is, affected, and, if you see that bedwetting happens between this midnight to, about 4 o'clock in the morning usually, and it also could be a, circadian rhythm disorder also bedwetting could fall into. I say this because if you look at the urine production if you look at, the night urine production, normally it will be less. But if in an anuretic child, the urine production in night is more than an average child. And if you look at the secretion of the antidiuretic hormone, in bedwetting kids, if you see normal children, the secretion, if you see that and compare with the children who are anoretics, then you see the, secretion is lesser in children who are bedwetters. So this has all been scientifically studied, documented, and published. So as I said, there is a lot of, impacts psychologically on children with low self-esteem, shame, embarrassment, and guilt. And, sometimes parents become very intolerant to bedwetting. They start scolding the child, sometimes they beat the child. So when you do an assessment of, for, national bedwetting, then you need to look at if, how the child feels about the problem. Also, to some extent, you should take their perspective. What is the pattern of their bedwetting? What are the associated symptoms? Look at that. Also look at their fluid intake, their developmental history, when did they attain, when did they to look at the maturation of the nervous system. Also ask for a history of UTIs, constipation, airway obstructions, abuse and stress. Not easy to, sometimes look at abuse and stress with a child because parents won't tell you and the child will not also speak to you. That becomes extremely difficult to assess. Look at previous interventions, any family history of bedwetting, and family history is very common, at least in my group of patients, whoever I see, at least one parent usually has had bedwetting. Also, you need to screen for bedwetting, when you do a diagnosis, because this, when you as a pediatrician, a dialogue should be asked to the parents whether they have bedwetting. You can initiate the dialogue. It is not a bad idea to do that. As I said in my earlier slide, sometimes parents are a bit reluctant to speak about bedwetting themselves. So as a clinician, you can do that. And then you can investigate into their history and do their physical examination and do some simple urine analysis. But urine analysis is not always, necessary. And then you establish whether it's primary or secondary and monosymptomatic or polysymptomatic. That also you can establish. You should rule out other conditions, of storage and voiding, and whether they have daytime bedwetting, and also look for whether they have type 1 diabetes. Chronic renal failure sometimes is missed. Sometimes there's overflow incontinence. That could be a cause of leakage of urine. That should be ruled out, especially with PUV, posterior urethral valves and so on. And then, once you've done the assessment, then your treatment goal should be to increase the number of dry nights for the child, and you should try and minimize the emotional impact of bedwetting. So you should try and establish, if you can in your clinic, a positive environment of the child, reassure the child, tell the parents that it's not the child's fault for bedwetting, and the child can be helped. That is the important strategy to give them reassurance and to improve the self-esteem of the child. Many of these children also don't do too well in schools also. So ask them what is their performance in school. And sometimes because of the psychological impact, some of the older children, they do have psychological impact, and some of them not necessarily do too well in the school. But it is surprising. Sometimes I also, since we started the bedwetting clinic, we also see sometimes young kids, who have not been able to outgrow, and I've seen kids as old as, in fact, I saw a young lady the other day who was 22 and she was still bedwetting, and she had never been counseled. So sometimes when you run a bedwetting clinic, you also see some young adults, and they're very embarrassed to talk about it. So that in the treatment, you take a stepwise approach, and also remember that some of these kids will have only partial response. But partial response is better than having no response. At least you have partial response. They get reassured that they will get out of it slowly. And so sometimes some of these children may require, especially when they come as the older kids will require longer therapy compared to the younger kids. So you need to look at some very common strategies which can be followed. I'm sure you've all tell this to parents that child should empty the bladder before before going to bed. They should limit their fluid consumption, eliminate things like tea, coffee in the afternoons, from maybe from 4 or 5 o'clock onwards, and then you should try and tell them that they need to get up to pass urine in the night, at least once in the night, and you should try and tell the parents to take the child out of diapers, and you should also ask the parents to include the child in the morning, morning cleaning up kind of, when they clean up the, all the linen, then, the child should be involved in cleaning up without scolding them or anything. So they feel that, yes, they feel involved, and they feel that, it is important for them to be dry in the nights. So, some of these simple strategies sometimes works wonders with some children. And I have seen in my clinic, it's very simple advice of making sure, asking parents to wake up the child once in the night at least, and to find out, what time in the night they actually bedwet. Some children will have, 2 hours after, going to sleep, and some children may have passed after 4 hours. So we need to know exactly what time the children usually wet their bed. Sometimes they'll, after even getting up at night, they'll again have a bedwetting episode early in the morning. So you need to find out what time it happens. And if you can advise the parents at least to practice for 2 to 3 weeks, waking up the child, because they are in deep arousal, deep sleep, and they are difficult to arouse. So if they're able to wake up the child at least once, then the habit gets formed. And many of the older children, at least if you follow the strategy, then, with these kind of even simple advice, you can get the child out of this kind of, problem of bedwetting. So you should try the simple strategies, at least I believe very firmly, although, there is the international literature itself thinks that, some kind of medication is better, but I feel we should try the simplest strategies in India, and sometimes it works. And now with the cell phones, it so happens that most of the parents, put their alarms on cell phones, and I think the cell phone alarm doesn't work. You need to have a proper alarm if you really want to wake up the child. So, there are the treatment approaches without any, drugs. You can use the wet alarms and behavioral therapy, and then you have of course, the drugs, pharmacological approach. And there are, as you all know, that Desmopressin is now available. We previously some of us used to use tricyclic antidepressants, but I'm not in favor of these antidepressants to be used on children. I have used anticholinergics, on children before the Desmopressin came on scene. We used to use anticholinergics, especially when the child, we would go out, for a picnic, or, had a night out. At that time, we used to ask them, parents, to use anticholinergics. I've used them in the past quite effectively. But, with the arrival of Desmopressin, that's more used more commonly now. So the wet alarms are available. They are available on Amazon. You can now purchase them. As I said, get a proper alarm clock for the child if you want to wake the child up. Sometimes even with this clock, it's difficult to wake up the child. And invariably, you need to have a strategy where a parent can wake up, or if there's an older brother or sister, siblings, then they can help each other and wake up and, wake up the child and make them pass urine. So, if the responsibilities can be split, maybe some days the mother does it, and sometimes if there's an older child or the father, they can do it. It'll be easier for the compliance. Otherwise, if only the mother has to do it, then she will get tired of waking up, and especially if she's working the next day, it doesn't work, the strategy doesn't work. So you really need to look at the family and give them proper counseling for it to really work, this kind of strategy to work. Otherwise, it will fail. The wet alarms are available. They do cost money. They are available on the, things like, places like Amazon now. And, so many societies and WHO, have this, do support the wet alarms, and wet alarms with Desmopressin estate also, Desmopressin also does give good results. If you can also use both if you wish. So, as I said, if you can involve the parents and the siblings together with the child, then, it is ideal, and then, and you also tell them that these are the options treatment options, and they can choose from these treatment options. So many of my patients, when I give them this advice, they first take the first option of trying to put a alarm, at least try for a month before they will go on the medication. But I always say that if you're going out somewhere, then keep the medication, keep a supply of medication. And if you're going out anywhere, do use it, because otherwise what happens is there's a lot of embarrassment in the family and so on. So for those situations, I always tell them, initially at least use those drugs. So the success rate with the alarms, again, this is all international study. We don't have anything available from India. The cure rate is a little less than 50%. And you can see, you need 2 months to see the improvement. If you want to, use better alarms, then you at least need to apply it for 2 to 3 months before you, will see some kind of improvement. And they'll get dry. They'll get dry as they go along. But there is a non-compliance rate, and 30% of patients do discontinue using, wet alarms. In my practice, I have advised parents to buy wet alarms, but many of them are reluctant to buy anything like this because, again, there are some electrical, some wiring and so on. So they are also worried about that. So what happens is the alarm, wakes the child up, but when they are in the deep sleep, that's the most difficult time to wake up the child. Sometimes even then they don't wake up necessarily. As I said, but it is good if you can use, if there's an older child, then the wet alarm works definitely better than a child who is about 5 or 6. And this is very common. Often the family wakes up, not the child. So what happens with wet alarms, that it goes off when the child starts to void, and then it teaches the child to wake up to the alarm. And then, the child understands, that this is the time they have to wake up, and so this is how the alarm works. As soon as they start getting wet and the alarm works, the child wakes up, and then they, to some extent, they can either stop. It's difficult for them to stop, but they can then, go and again pass urine if they wish in the toilet or into the the diaper itself, So it teaches them when to wake up before they void, So that kind of training happens with the wet alarms, That's what it does. What about the Desmopressin itself? It's, as you know, a synthetic analog of ADH. It's a formulation which only belongs to Ferring Pharma. Nobody else has the, don't have the, license to do it because this is their original molecule. The efficacy of treatment with Desmopressin is over 80%. It is advised to be used in children over 5 years. I use it in India over 6 years. Older, I feel, we should give a child who's 5, who's still bedwetting, a chance to get dry. So I usually postpone it till the child is about 6 years in India. And the response is very good. I've seen that, in fact, within a few days of giving, even with the first dose, I've seen parents come back and say that the child is dry and they're very happy with the tablet. Usually we advise it for 3 months, to take the tablet. If they wish to take the tablet, I do give the option to the parents. If they're in a hurry for treatment, then I tell them, okay, we'll start the treatment. But before I do that, I usually will give them a voiding diary for 3 to 4 days to understand how much they're drinking, how much they're voiding. After they only come back to the voiding diary and I've done the assessment, would I advise something like, Desmopressin if required. And if they stop being, after Desmopressin, we give them a break. And sometimes, they will not come back, and sometimes they'll come back. Then we have to reinitiate if they have, again, bedwetting episodes. So, as I said, if you see the clinical response with 0.2 milligram tablets, there are also there's available called Minrin. So there is, overall 90% reduction, of wet nights, there'll be complete 50% you have full reduction, and in less than 50% you have partial reduction. So overall you'll get about 90%, dry nights kind of thing, but, not necessarily fully. So the response rate calculated is about 64%, 84%. We don't advise you to use the spray of Desmopressin because there's a high incidence of hyponatremia with that. So we don't use it for nocturnal enuresis. The tablet is available as 200 microgram. but it requires to take a tablet. It comes as minerin, but the child will require to take some fluid. So what they advise is to take a tablet which melts under your tongue, the child's tongue. So they don't need to take any extra fluid to take the tablet. And this is available as melt as 120 micrograms or 240 micrograms available. Two formulations available. I usually use 120. And if you look at the duration of action of the lyophilized desmopressin or melt, you see that the action is for about 10 to 12 hours. The tablet's action is longer, for up to 14 hours, but the spray has the longest action, almost goes on to 20 hours. So the melt kind of suits the child's requirement of sleep to be dry. So so sometimes we do use tablet because the tablet is cheaper than the lyophilized formulation of desmopressin, the melt. So sometimes we also start the tablet first, but if the response to tablet is not good, then we give the lyophilized version. But now I have after experience of using both the medications, I realized that I use the desmopressin tablets mostly in adults to treat nocturia. Because I find when I use for melt in the elderly patients who have nocturia with BPH, then it causes more hyponatremia. The melt causes more hyponatremia. So, but with desmopressin tablets, I don't get so much of hyponatremia. So in children, I always usually use only melt, the lyophilized version. And obviously, most of the trials show that the compliance with melt is better than tablets. So as I said, I use 120 micrograms, and usually half an hour to 1 hour before they go to bed, and we starting with 3 nights, see how they are. And normally it is advised that if they're not dry with this 120, increases to you can go up to 360 if you want, but I have never used more than 120 so far. I've not had the requirement to use 2 melts instead of 1. Most of them will get dry with just 1 tablet, but one lyophilized version under the tongue. Sometimes you may require 2, but I think that at least in my practice, 120 seems to be enough. And it is usually advised that we should keep treating them as long as their symptoms persist, usually for 3 months, and then evaluate the patient. Evaluate the child, and then after 3 months, give them definitely a drug holiday and see whether the child is dry. And if the child is dry, great. If the child is not dry, then ask them to come back. If you look at the level of evidence with the different kind of formulations, the level of evidence is very high with desmopressin or desmopressin plus alarm combination. Both work very well. Also is very high, in fact, with the antidepressants. They work well, but I'm not very happy using them in children. Anticholinergics, the level of evidence is 2. Alarm, again, have a good level of evidence, especially if the child is motivated, the parents are motivated. So alarm does have some place. Arousal training has a very weak level of evidence, is at 3, but if again it depends on the motivation. If the child is motivated and if the parents are motivated, then you can still, of course, use it. So, in summary, bedwetting significantly impacts the self-esteem of and it does instill shame in children. Bedwetting needs to be diagnosed as part of routine examination. It should be, you should ask maybe as for when you ask, when you screen when you actually take history of some first time you're seeing a child, do ask, in their routine visits. And you need to have the parents and children involved actively in the treatment, whatever you plan. The wet alarms are a viable option, in highly motivated parents and children. The cure rate is, about around 50%. The desmopressin, the lyophilized version, is safe, is very effective in children. It has a high response rate. As I said, efficacy is over 80% with this tablet. There's less food interaction when you give the tablet. And when you give melt, rather, between melt and the tablet, melt has less food interaction. You need to restrict fluids intake for 1 hour at least before they go to bed. And, the child should go to toilet for their final void, before they go to sleep, And if you should treat the child for, about 3 months and then give a drug holiday. So, as I said, we now are celebrating also World Bedwetting Day just to create awareness. And thank you very much for listening me out. And I'll be happy to answer any questions.
So we'll take the questions at the end of the session. Thank you, Dr. Shroff, for the wonderful talk. So basically, like the way you've covered the entire topic, and especially the psychosocial impact of bedwetting, I mean, that speaks volumes. The case that you mentioned about the suicide of this adolescent child, I mean, that speaks volumes about the psychosocial impact of bedwetting, and hence the integrative approach to the therapy of bedwetting. Thank you so much. So
thank you, Shweta.
Thank you. So now over to Dr. Satya Prasad. He's back for the next talk. Thank you. Please, Dr. Satya Prasad.
Yeah, thank you. Sorry for the interruption. Are you able to hear? Hello?
I'm able to hear you, Satya. What you need to do, I realize, you need to click on the side screen to get your slides. Otherwise, you will keep jumping. Don't use the previous and next.
Sure.
The previous and next doesn't work well. So I learned it,
Okay, sure.
That's why I may not have been sometimes coherent. Just use the side one, yes.
Yeah, sure, yeah. Yeah, so we have gone through few slides. I have finished half, so I'll start again from the in mid. Sorry for the break.
Prasad sir, sorry to interrupt. You can start your slides from the beginning because we did not hear any of your presentation. It was from the beginning. It was low.
Sure.
And plus the flow of the thing will be
sure.
So it would be great to have it.
Yeah, sure. Yeah. Are you able to hear now clearly?
Yes.
Yeah.
Carry on.
Yeah, sure. So, sorry for the interruption. I'll start again. So, voiding dysfunction is a broad term used to describe conditions where there is an inconsistent coordination within the urinary tract. It might be because of incomplete relaxation or overactivity of the pelvic during voiding. What are the objectives? First, we should know how lower urinary tract works. So we should define properly, and we should know different presentation modes, and we have to evaluate properly so that we can give effective treatment. How the lower urinary tract works? The main function is storage and emptying. Bladder should store adequate volumes of urine at low pressures without any leakage. Coming to emptying, emptying is a voluntary act. It should be efficient and complete. Bladder should empty completely without any post-residual volume at low pressures. What is the functional integrated part of lower urinary tract? It comprises of uretrovesical junction, urinary bladder, sphincter, urethra, and all these are under control of signals from brain. If control is intact, then voiding should be very smooth, without any interruption. What is the anatomy on neurophysiology of the lower urinary tract? It comprises bladder, urethra, and sphincters. What is the function of bladder? Should store adequate amount of optimum amount of urine at low pressures, and it compresses so that it voids urine completely. The function of urethra, it conveys urine from the bladder to outside world. What is the function of sphincter? It controls urine flow and maintains continence between voidings. Coming to definitions, Already Dr. Shroff had discussed about it. So this is a normal voiding that occurs at inappropriate time or involuntarily in social unacceptable settings. Most common thing is nocturnal enuresis. Already we discussed effectively. Next thing is Dionyl enuresis. Coming to Dionyl enuresis, this is often interchanged with the dysfunctional voiding, but they are not the same. Not all dysfunctional voiders are incontinent. Dysfunctional voiding can be neuropathic or non-neuropathic. Neuropathic voiding disorders usually you will see in conditions like spinal bifida, transverse myelitis. It might be because of spinal cord trauma also. And non-neuropathic functional voiding problems, it mimics neuropathic bladder. So we should treat effectively these kids also so that we can prevent kidney damage. Coming to characterization of voiding dysfunction. Two things here. One thing is storage problem. Other thing is emptying problem. Coming to storage. Failure to store normal urine at low pressures without leakage. This is the important function. If not able to do that, because of non-compliant bladder or maybe because of irritable bladder, problem, or it may be because of problem in sphincter during filling. Coming to emptying, failure to empty bladder completely on command efficiently at low pressures. This is because of failure of neurological control of bladder. It might be because of bladder muscle failure or maybe failure of sphincter during voiding. What are the clinical problems from voiding dysfunction? If bladder pressure increases, it results in vesicoureteric reflux. If reflux is there, it might lead to recurrent infections. It results in upper tract damage. And because of high pressures, they develop bladder hypertrophy, leading to detrusor failure. And because of residual urine, it leads to recurrent infections. And incontinence is a social issue, and it leads to social consequences. And in kids to depression, and it affects studies also sometimes. So voiding dysfunction in children without any organic pathology. What is the presentation? Usually they'll come to our OPD with urological presentation, gastrointestinal presentation, or sometimes they'll have occult neurological presentation. What are the different urological presentations? It might be they'll have infrequent voiding. Sometimes they'll come to OPD with frequent voiding. They'll have urgency, dysuria. Sometimes they'll have different holding maneuvers like Vincent's curtsy, crossing legs, and straining, or maybe because of with poor stream, intermittent stream, incomplete emptying, incontinence, and with recurrent UTI episodes. Coming to GA, what are the usual GA presentation? They'll come to OPD with fecal staining of undergarments, with fecal incontinence, constipation, encoparesis, sometimes with recurrent abdominal pain. What is occult neurological presentation? Early detection may prevent neurological damage. Complex spina bifida occult is an important disease entity because of its prevalence. You can see this in 1% of population. And any child coming to OPD always look back how the spine is. Look for reverse, dermal sinus, or a dimple. Look for any abnormality. This information about problem in spine, which leads to neurogenic bladder in future. Coming to types of voiding dysfunction. Overactive bladder. This is the most common type of voiding dysfunction, and it occurs in around 20 to 25% of children between age groups of 5 to 7 years. Here what they do, they try to hold it by crossing their legs or using other physical maneuvers. Coming to dysfunctional voiding, this is characterized by dysenergic striatal sphincter activity in the absence of a proven neurological etiology. Here, bladder never fully empties. And the symptoms are similar to neurogenic bladder and they are at high risk of complications leading to renal failure. Underactive bladder, this is due to detrusor underactivity. Here you will see prolonged bladder emptying, and it takes long time to empty. They won't pass urine for a long time even throughout the day also. Coming to voiding, different voiding dysfunctional disorders, minor. This is, first one is extraordinary daytime urinary frequency syndrome called as polyuria. This is a benign condition, usually self-limiting. Giggle incontinence, stress incontinence, giggle incontinence while laughing. This occurs in girls. Stress incontinence because of high pressure of the bladder during physical activity, exercise. This happens. Post-void dribbling, vaginal voiding. These are the minor voiding dysfunctional disorders. Coming to voiding dysfunctional disorders, which require immediate attention. If you don't treat these things properly, it might lead to kidney damage. Coming to Hinman syndrome, this is called non-neurogenic bladder. This is because of incoordination between detrusor muscle and sphincter. If this is associated with autosomal dominant inheritance along with facial grimace, this smiling, this is called urofacial syndrome. Then urofacial syndrome people, they'll have symptoms of Hinman syndrome, and if you don't treat, they'll go into renal failure. The next thing is myogenic distraught failure. It may be because of over distension of bladder. For a long time, it leads to myogenic distraught failure. Other things, Urge syndrome, bladder sphincter dysanagesia, and lazy bladder syndrome. We'll discuss about it. Coming to Urge syndrome, what it is, what happens during filling here. Multiple uninhibited detrusor contractions with increased EM activity and expression of urgency. Usually voiding is normal here, and you won't see any post-viral residue here. Coming to bladder sphincter dysanagesia, here filling phase is normal. During voiding, you will see increased EMG activity causing diminution or interruption of urinary flow. Again here, post-residual volume, sometimes it may be 0, sometimes it may be variable. They'll have significant amount sometimes if incoordination is severe. Coming to lazy bladder syndrome, here filling is abnormal, voiding is abnormal. During filling, they'll have abnormally capacious bladder with little or no expression of urge. During voiding, they'll have prolonged decreased flow with abdominal straining and burst of EMG activity. And always they'll have post-voidal residue, which leads to recurrent infections. How to evaluate voiding dysfunction? The purpose of evaluation is to diagnose properly so that we can treat effectively. Characterization of elimination problems is very important. So we should know about storage problem, emptying problem, and continence problem. And always rule out urological organic causes also. Coming to evaluation. For evaluation of dysfunctional voiding, not only dysfunctional voiding, for any disease, proper history is very important. Along with the proper history, physical examination is also must. History. First, characterize the problem. Voiding symptoms and pattern of incontinence must be quantified. Look for any history of urgency, frequency, straining, or dysuria extra. Look for any holding maneuvers such as leg crossing, squatting, or Vincent's curse. These things will give information about voiding dysfunction. And continuous incontinence in a girl suggests ectopic ureter. Urethral sphincter that leads to continuous incontinence. And characterize the problem. This starts with history of current elimination problems, like take history of detailed voiding history, detailed stooling history is also important, and any past history of this, like recurrent UTIs or chronic constipation. These are very, very important, and we have to treat effectively these things. And take history of fluids and diet also. If child is not taking fiber diet, the child is not taking adequate amount of fluids, obviously that leads to constipation, and that leads to recurrent infections, and that leads to voiding dysfunction sometimes. This is the vicious circle, so we should be very, very careful. And take history about family, whether any family member is having any urological problems. These are the different type of holding maneuvers, like crossing legs and Vincent curtsy already we discussed. This is the ectopic ureter opening into the urethra. Physician must uncover that the child with wetting problem actually has abnormally few voids and big bladder. This is about infrequent void. Here, sometimes they won't pass urine throughout the day also. And usually they might void 2 to 3 times daily. Sometimes even they won't void during the daytime in the school. This is because of large bladder, because of failure of destruction. And this leads to significant amount of post-residual volume leading to recurrent infections. And always, not only non-urogenic bladders, think about organic pathology, which leads to voiding dysfunction. So take proper history about diabetes, take history of seizures, epilepsy, and take history of obstructive sleep apnea. All these people will have voiding dysfunction. Look for any neurological issues are there or not. If all these things already, if you have taken proper history, all things if you have ruled out already, then most commonly this is more like functional. And sometimes voiding symptoms may be a sign of sexual abuse. So that history also we should think. Sometimes stress might lead to incontinence. So that history is also very, very important. After history, the important thing is examination. If we examine properly, proper history and proper physical examination, with these two, you can diagnose 90% of cases. Growth, general health, vital signs including BP. Inspect child's underwear for any evidence of wetness or soiling. Also, or at least listen to voiding for evidence of weak, slow, or intermittent stream. Examine for any renal masses and look for any distendal bladder and look for any fecal loading, fecolith. And look for any signs of erythema or irritation. These are indication of vaginal soiling. Metal stenosis in boys and presence of labial adhesions in girls. These also can lead to vital dysfunction. And signs of trauma are suggestive of abuse. And look for any ectopic anus. Usually this is associated with sometimes BUR and ectopic insertion of ureter that leads to voiding dysfunction. After physical examination, next thing is labs. Simple routine investigations are enough. Do complete urine examination. If C is showing pus cells, if really symptomatic, do urine culture also. Then do routine renal function test including electrolytes, urea creatinine, if required, do metabolic workup like bicarbonate, calcium, and those things also if you are suspecting kidney disease. And all never forget to look random blood sugar. Any child with increased frequency, always we should rule out diabetes also. Imaging, simple imaging like take X-ray, abdominal X-ray that gives information about sometimes lumbosacral anomalies, bowel gas, and gives information about fecal loading also. And routine simple ultrasound with PVR, that is very, very important. If you are asking for ultrasound, always ask the radiologist to look for post-voidal residue also, especially if you are dealing with voiding dysfunction. So in sonography, you have to look upper tract, look for size, contour, and echogenicity, and presence of hydronephrosis. In lower tract, you have to assess bladder wall thickness. If this is more than 3 millimeter, that is significant. And look for post-voidal residue. If this is more than 2 ml per kg, which is abnormal. Coming to scans, if child is having recurrent infections, BUR is there, and having secondary reflux, then always you have to look for nuclear imaging. Do DMSA scan to look for any scars. If child is having hydronephrosis, gross hydronephrosis, look for any obstruction, whether at TUJ or VUJ. So you do functional scan, ECR max scan. This gives information about obstruction. Any child with recurrent infections always do MCG also. And if family history is there, always is better to do in sibling also to rule out reflux. Rarely they require Uroflometry also. If you are dealing a child with voiding dysfunction already, if you have done all investigations, if investigations are not conclusive, do Uroflometry. And sometimes they require invasive urodynamic study also, which gives information about bladder pressures. And we can treat effectively if you know appropriately the pressures and leaking pressure and all those things. Coming to management of voiding dysfunction in children with no treatable organic pathology. Non-pharmacological. Any child with voiding dysfunction, first important thing is timed voiding. Any child more than 2 years, we can ask the parents to do toilet training. So timed voiding is the easiest, most effective treatment. It works for irritable bladder and infrequent voiders. And ask them to go to bathroom once in 2 to 3 hours during daytime. Apart from that, biofeedback mechanisms and Kegel exercises, these are also very, very important things to treat non-pharmacological. Coming to pharmacological, usually if we are dealing a child who is having irritable bladder and non-compliant bladder, sometimes they'll be benefited with oxybutynin. Dose is 0.1 to 0.15 mg per kg, or dose in 3 divided doses. Usually, sometimes it causes dry mouth, constipation. These are the minor side effects. Coming to antibiotic prophylaxis, this is controversial. Usually, we won't use unless the child is having recurrent infections with secondary reflux. Child is having symptomatic UTI, then we can use, yes. Otherwise, it's better to avoid antibiotic prophylaxis. And never forget to treat constipation and gallbladder dysfunction. If child is having constipation, always ask them to take lots of fiber, lots of liquids. Along with that, sometimes you have to give laxatives also. UTI, VR, and elimination, these have strong association. That's why we have to treat all these things effectively. So coming to voiding dysfunction in children with neurogenic bladder. Usually they'll come to OP with incontinence, urological obstruction, which leads to elevated intravesical pressures. Because of that, they'll develop secondary VUR, and they're at risk of UTI. And sometimes because of so much of residual urine, it leads to stones in the bladder. So what happens if there is a lack of higher CNS control? This causes detrusor is controlled by unmodulated spinal reflux. Sphincter with fixed passive resistance, that is called leak point pressure. This is very, very important. If bladder pressure is less than LPP, you won't see any leakage. If bladder pressure is more than leak point pressure, then obviously they'll have leakage of urination. High LPP pressure is good for continence, but this is very bad for kidney. Because of high pressures, it leads to secondary reflux and damage. Prolonged LPP more than 40 centimeters of H2 have been associated with secondary VUR, upper tract deterioration, and decreasing bladder compliance. So focus on preservation of renal function. For this, what we have to do? We have to maintain normal blood pressure during, normal bladder pressure during filling and voiding, minimizing UTI. These are the very, very important. We have to focus on these things. What is the treatment of neurogenic bladder? If child is having low LPP, normal bladder function, observation is enough. If child is having flaccid bladder, unable to empty, then they require CIC. If child is having hyperrefluxic, non-compliant bladder, then we have to do CIC with anticholinergics also. And usually CIC is needed once in 3 to 4 hours. And if you are dealing with neonates or infants, even though if you are doing CIC, if kids are having recurrent infections, and if you see any deterioration of upper tracts, always it's better to do ischectomy. One child is big, obviously we can close that. In older children, CIC can be made easier with continent catheterizable stomas like metrophenol. Here usually we can use appendix as conjugate or sometimes even intestine also. Coming to bladder augmentation, this is indicated when medical therapy fails to achieve adequate low pressure capacity with continence. Here, for bladder augmentation, we do use variety of substances like small and large intestine, and sometimes even stomach. Sometimes we can use ureter from if kidney is not functioning, non-functional kidney. You can take the ureter, you can use it for bladder augmentation. But if you're using intestine, sometimes they'll have electrolyte imbalance. This is because of secretion of electrons into the and do religious CAC. If you do aggressively, sometimes you might rupture the augmented bladder. And usually in 40 to 65% of urogenic bladder patients, you will see secondary VUR. Here treatment is aimed at reducing bladder pressure rather than fixing the VUR. That's why do regularly CIC, do bladder augmentation. Coming to prophylaxis, already we discussed, this is controversial. But if child is having recurrent symptomatic UTI, then yes, we have to give antibiotic prophylaxis. But always use narrow spectrum antibiotic for the shortest possible time to prevent antibiotic resistance. Take home message, detailed history and physical examination is important. Reassurance and psychological support is vital. And if you don't treat properly, inadequate management can lead to renal impairment. Thank you very much.
Thank you, Dr. Satya Prasad, for a very comprehensive and lucid talk. You have covered all the aspects of voiding dysfunction in a very comprehensive manner. And thank you so much for the talk. Now the floor is open for questions. I'll take some questions now. Second, please. The first question is for Dr. Shroff. How long can we allow wet alarm or behavior therapy before starting the medical management?
Very good question. I'm not able to see anybody, but I can you hear me?
Yeah.
Can you hear? Yeah, am I audible?
Yes,
Very much audible.
Yeah, so somehow I'm not able to get back to the view of presenters. I don't know why, but anyway, good question. So the normal, it all depends how motivated are the parents and children. Normally, you want at least 12 to 16 weeks of behavioral therapy before you would really give it up totally. Sometimes you'll see result, if the motivation is good, within 2 to 3 weeks when they come back for the second visit, they will say that, yes, we are having more dry nights. And sometimes it doesn't work. So ideally, 3 to 3 months you should try behavioral therapy, but sometimes, parents don't want to wait so long. So what I do is I also look at, before I start behavioral therapy, what I do also, I'll tell you, I look at the functional capacity of the bladder. Some of the children have, less functional capacity. That is very important to determine. So I normally will do a Euroflow in the clinic only to determine what is the capacity of the bladder of the child. And if the capacity of the bladder of the child looks good, then I definitely encourage them to try behavioral therapy. And, as I said, depending on motivation, many of these children will learn. So I can't give you a fixed rule as such, but in literature, they will say 12 to at least 12 weeks to 16 weeks, you should try it out. I, in my practice, will always try it definitely for a month. And if they don't come back after a month and say that the child is still wet, then I would add a medication. And I use this. I counsel the parents and ask them whether they want to continue behavioral therapy or not. And many parents will say, no, we are, can we try something? But sometimes it so happens that if you make the child dry, then the child feels very, especially when you get an older child, they feel more confident that they'll get dry. Sometimes, there's this feeling of being defeated that, they'll never get dry. Some children have that in their mind. So to build their confidence also, sometimes a medication, intervention is good to give. as such, So 1 month, I would say 1 month, 6 weeks, and after that, you could start medication. That's what I do in my practice. I hope I have answered the question adequately.
Dr. Shroff, the next question is again for you.
Yes.
So, Desmopressin, is it given orally only, or intranasal can also be tried? I think you've answered this question, but since the side effect is humongous, I think it's a good idea to re-answer the question so that the take-home message is there for this. Yeah.
Sure. So the nasal preparation of Desmopressin is long-acting. It can work for almost 18 to 24 hours, and we don't use it in nocturnal enuresis. Because it also causes hyponatremia. The incidence of hyponatremia is much higher with the with the spray, so we don't use it. The tablets can be used, but again, the tablets, the action is about 14 to 16 hours. Your requirement is only for 8 to 12 hours to keep the child dry. So ideally, I think, if you use a lyophilized version of Desmopressin, which is available as a melt, it is better. And I would suggest that you use 120 micrograms to start off with. Am I still there?
Yeah. So the next question is, in neonates with meningomyelocele, is starting prophylactic CIC early in follow-up period beneficial, or should we wait till the baby develops hydronephrosis, hydroureter UTIs, and then start CIC? I think Dr. Satya Prasad can take this question. Hello?
Yeah, I'm able to hear. So any child, suppose if child is having meningomyelocele, so always it's better to do routine ultrasound. Then if child is having bladder wall thickening, even without hydroureter nephrosis also, we should be careful. So we should do early intervention, look for any secondary reflux, do MCUG. If reflux is there, we should be careful, and look for renal functions. If child is having any rise urea and creatinine, then obviously it's better to start early CIC. If child is having normal bladder without any hydroureter nephrosis, we can observe, but regular investigations are very, very important. Then we have to look for UTIs, because if any child with spinal dystrophism, if child is having any symptoms like fever, vomitings, even without any symptoms of UTI like dysuria, because small babies, it's very difficult to elicit. Do CUE if any doubt is there. If infection is there, treat it. If bladder wall thickening cystitis is there, then it's better to do MCUG, rule out reflux. If secondary reflux is there, then it's better to start CIC, early CIC, to prevent future damage to kidneys.
So just to add a bit, maybe like if you see that the baby has got paralysis of the lower limbs, or the urinary stream of the baby is not adequate, that would be a pointer towards starting early CIC. Because
and other thing is, you have to look for any palpable bladder also. If child is having any palpable bladder, then again, so we should be very, very careful. Yeah,
because the catch is that we'll be unable to really assess the bladder of a neonate. So yes, yeah.
It's a very...
Sometimes neuropathic bladder, usually they'll have, if a significant problem is there, severe problem, usually they'll have palpable bladder also, which is an indication to start early CIC.
So, Dr. Shroff, based on this question, would you do a Euroflow in a neonate? Because I think Eurodynamics would not be possible, but Euroflow?
Again, the Euroflow also can be challenging, because you don't know, we can't predict when the neonate is going to actually pass urine. So that's not easy to do usually in children when they don't have control as such. Only thing I would say in such a situation is you need to be very vigilant, because these are the children who lose their nephrons very fast if you don't keep track of their kidneys function. Because we have seen children who do have, meningomyelocele, having neurogenic kind of element of the bladder, and that really knocks off their kidney very early before you realize it. So that kind of vigilance should be very high, and early intervention is definitely advised. And if necessary, we have done, not in neonates so much, But in young kids, who are 3 or 4 years old, we have actually given general anesthesia and then done urodynamics on them. Quite routinely, we used to do it in the pediatric age group, of that age group in England at least. In India also, we have done that in some of these children. But this is more of a team effort between the pediatrician, pediatric nephrologist, and the urologist, so that the child is seen together, so that things are not missed. And if required, I would go as far as giving an anesthesia and doing urodynamics in the children, where documentation is very important of the bladder pressures. But doing a team effort is what is the key in this, to save the child's kidneys.
So I think the take home
even they require vesicostomy also sometimes.
Yes,
sometimes they require even vesicostomy if recurrent infections.
In bigger children, yes. So, so the basic thing is that you have to go as per your clinical judgment, and also follow up has to be emphasized, and follow up has to be really done well. And this cannot be overemphasized to the parents.
That's why
I think sometimes they'll.
Sorry.
Yeah, please, sir. Yeah.
No, I was saying a dedicated pediatric, unit which looks after these children is always very ideal in a tertiary care hospital, where you have the nephrologist and the urologist, and perhaps the neurologist also working together as a team. And that is what we need to build in India as well, for this age group of, for this type of kids. Abroad, many of these kids get aborted, they're not even born. But in India, we still get a lot of these kids coming in. As with time, with ultrasound and so on, many of these children are, at least the ones which have gross deformities are picked up early. So you get, less kind of problems now abroad compared to what you get in India.
Another important thing is usually they behave like type 4 RTA. Usually they'll have acidosis, hyperkalemia, so treatment of all those things, regularly checking electrolytes, breakup, all these things are very important in neonates with spinal dysraphism. That is also very, very important.
Right. So next question for Dr. Shroff, sir. Role of Desmopressin and Dionyl Anaerosis after achieving bladder control.
If you have achieved bladder control, as I said, you give them a holiday and look how they do. Give them, at least a month to see. But one other thing which you must also tell the parents is that waking up the child in the night is always, always good. And that practice should be, kept going if possible. But, if they are also bedwetting in the daytime, then you need to really investigate the child further to know if there are other problems with the child, and start looking for other pathologies, organic pathologies, which may be there, which you may have missed. So you really need to look deeper into the whole situation, especially if they have always had, daytime bedwetting as well, along with night, then there is something more going on. And I will not depend on Desmopressin as a treatment option before I get my diagnosis right,
Right. Right. So what does biofeedback include? That's a question for Dr. Satya Prasad.
Yeah. These are like physical exercises. Usually physical exercises, if you do properly, that increases bladder capacity. So this is very, very important. Practice, and it decreases stress also. So regular yoga and exercises, all these are very, very important. So this increases self-esteem and this is bladder capacity also. And do time voiding. All these things are important. Do pelvic floor exercises, means regularly take in and out breathing in laying down position. Do that for 3 to 4 times. Wait for a few seconds and do it again. Like that, you have to do 10 times in a day. If you do that, obviously we can increase the compliance of the bladder.
The biofeedback also works in situations if they have a low functional capacity of the bladder, then sometimes if you ask them to hold for a little very short time, 5 minutes, and then go on to 10 minutes and so on, that also helps to improve the bladder capacity as they go along. So that kind of thing also helps. And again, it works well for lazy bladders in especially among the girls, where you tell them to do time voiding. And that also helps the children to gain some confidence.
When to use Euroflometry in children? I think Dr. Shroff can take this question.
Yeah, so as I said, when I get a patient with bedwetting, nocturnal enuresis, in that situation, I do a Euroflow just to measure the bladder capacity of the child as well, and also to have a baseline study to see that, I'm not missing anything, with a poor flow. It's a very simple test to do. It's not very difficult test to do. For a child who is about 5 or 6, they easily do it. They just have to stand in front of a funnel and pass urine. So it's a very simple test to do. And it does give you a lot of parameters and gives you a comfort level before you start any treatment. So we use it as a urologist. We use it very commonly as such, at least in nocturnal enuresis, and I would use it in any child who has voiding dysfunction as well. Because compared to urodynamics, Euroflow is such a simple study, and now it is more and more easily available. So I would use it more frequently, and my kind of threshold to use it is slightly, lower compared to perhaps other people, for using Euroflow, because it does give you a lot of information. And it's a very simple study.
Behavioral therapy in what form? Please elaborate. Dr. Satya Prasad can take this question.
Yeah, behavioral therapy again is same thing. So important thing is this is useful in kids with psychological issues, stress, anxiety, with these issues. So if a child is having any depression, we have to treat that. And we have to train them to go to bathroom once in 2 hours. And we have to give lots of fiber. And if child is having any infections, we should treat that. And these are very, very important things.
Just to add, another thing that helps in behavior therapy in children who have voiding dysfunction, especially if you have documented a large PVR, is double voiding. Like after the child voids, ask them to count 10 slowly and then void again, so that whatever post-void residue that they have had in the bladder, that will also be evacuated. Another thing is to address the constipation. The bowel habits have to be addressed in behavior therapy, basically. Yeah. All right. Next question for Dr. Satya Prasad. What's your opinion on biofeedback therapy for voiding disorder? Example, overactive bladder. I think you've already answered this, but would you like to emphasize further points on this? Yeah.
Same thing, overactive bladder. So this is because of the problem in tetrasal muscle. So irritable bladder, here they require regular exercises. Pelvic floor muscle, we have to strengthen it. Further, we have to do regular exercises. If you do that, then obviously it will be useful. So, and
I just wanted to make a quick comment on that. My impression with biofeedback is more towards stress incontinence, and as far as overactive bladder is concerned, our impression as urologists has been that it is a very poor kind of result with biofeedback. Stress incontinence, yes, there is good results we get, with biofeedback. That again is a little challenging because again compliance is not necessarily there, with some of the patients. So it is all how motivated the patient is. But as for overactive bladder biofeedback in our kind of routine practice, we find very poor kind of results.
Yeah. So for Dr. Shroff, is there any certain age when you decide to give Desmopressin straight away over alarm in nocturnal enuresis?
I first asked them whether you tried this waking up in nights. Believe me, even in the older age group, many parents have never tried it. So even in fact, the young adults, when I see them and ask them this question, they also have not tried it. So once I have measured the functional capacity of the bladder, and if I see the capacity of the bladder is good, then I'm very comfortable trying to tell them about, waking up in the night, very simple measures of, stopping the liquids in the evening and so on. And believe me, if they have been wetting bed, let's say 3 times in a week, it will come down to once, and that itself is a partial response, and that also gives them confidence. I'm a bit reluctant to start Desmopressin straight away, even if it is an older child or a young adult. If they have tried all these measures and that has failed, then I will go for the drug treatment. And then again, I ask them, how long have you tried? Because for actually a behavioral therapy to set into your psyche, it takes time. A minimum of 3 weeks. If you don't wake up every day in the night, you're not going to overcome your problem. I tell them 3 weeks is the minimum you have to try waking up in the night, and I tell the mother and the parents that you need to wake up at least for 3 weeks, if not more. That's the minimum. So that is what I use in this one. To give drugs is very simple to write drugs and send the patient away. I always tell them that use this first. If it doesn't work, please come back, and then we'll take it forward. That's my approach. But I do know clinicians who start Desmopressin, in the first visit, especially when the older child comes. But I don't.
Ideally, I think behavior therapy should be offered first.
Yes.
That's it. So next is a comment as well as a question. So hats off to Dr. Sunil Shafsa for handling pediatric topic. And your comment on voiding scores, please.
So I'm so sorry I didn't show you the voiding diary, which I should have. But what happened was in this, when the technology was playing up, 1 or 2 slides sort of got missed. So in the assessment of a child, I told this perhaps later on that I always use a voiding diary. I first give them a voiding diary. We have a kit actually, where we have a voiding diary, how much they drink in the night, how much they drink fluid-wise and how much they void. So we give them a kit first when they come to the clinic. And they take the kit home, and that's freely given. And thanks to Ferring for supporting us with the kit. So we give them the kit to take home, and that has a voiding diary with the voiding scores and so on. And when they come back with the voiding diary and the scores and how much they drink and so on, only then we start any treatment for that matter. In the first visit, we counsel them. We do some basic investigations, including in my clinic at least a Euroflow to measure the functional capacity of the bladder, get a very detailed history of the child, look at the motivation of the child and the parents, and then we can ourselves predict which kind of parents are going to work on this and which parents are not going to work on this. That it gives us an indication when we take a detailed history. And that's why in my clinic, at least I have a physician assistant who spends at least 20 minutes with the parents and the child to understand the whole thing. And then we have actually a full, kind of documentation of that before they come and see me. So they already spend 20 minutes with the physician assistant, and then they spend another 10, 15 minutes with me. So that's why we run the bedwetting clinic. I'm extremely sorry, Dr. Prabha. I didn't mean to miss it, but it just happened. The technology just made me concentrate more towards making sure that I run my slides rather than, not be able to do that. Sorry about that.
Yeah. What is the minimum age to do urodynamic studies?
This is a good question. Ideally, we don't want to, anesthetize the child. We don't want to give anesthesia to the child, ideally speaking. So, once they are 7, 8, even then they are very anxious. Children are very anxious in putting tubes inside, their tracts, both in the rectum and the urethra. They're very anxious. Many children have gone through a lot of pathology themselves. They've gone through a lot of investigations. Even for that matter, MCU is very traumatic sometimes for children. It's not so simple test. Putting a tube in the urethra itself is very traumatic to a child. They don't want to see doctors. They don't want to see white coats. They don't want to see injections. They don't want to see needles. So, it all depends on how much of pathology the child has had before, how many visits the child has had to come to the hospital. But if a child is very anxious, then we will do urodynamics only under anesthesia. And that's our usual routine. So there is no something, I can't give you a sort of minimum age. It all depends on what is the requirement, what is the pathology you're dealing with, what's the kind of bladder contour you're dealing with, what's the creatinine you're dealing with. Even if it's a 2 or 3-year-old child with a high creatinine and there is some indication that the bladder is showing overactivity, there's a fertile bladder, there's a neurogenic bladder, then you might need to do urodynamics even at that age group. It doesn't matter. It really depends on what the child presents with. Then only you decide urodynamics. If you can postpone urodynamics in children, then you want to do it in a slightly older age group of children. I hope I have answered that question adequately.
The next question again is for Dr. Shroff. What is the difference between Euroflow and Eurodynamic studies, and when do we perform either of them?
So I think Kalai has got another session she wants to do on Eurodynamics. She was telling me, maybe we can answer that. But to answer very simply, Euroflow measures the velocity of urine, how fast the urine is passed over what period of time, what is the volume of urine passed. And with Euroflow, we always include also a post-void residual to see how much of urine is left. So we measure what is the maximum kind of, what is the peak, velocity of the urine, and what's the volume of the urine. So we measure that by Euroflow, whereas with Eurodynamics, we say, volume pressure study. That study measures both filling pressure of the bladder and the voiding pressure. So there are two pressures you measure. And then you decide whether there's any abnormality also. Along with that, you also look at the EMG to look if the sphincters are working at the wrong time when they should be voiding, and if there's dysenergia. So Eurodynamics is a more elaborate study. It's a volume pressure study, whereas Euroflow merely measures the velocity of your urine. It is just a voiding study as such, without pressures.
What about star chart, the benefit of star chart?
That again depends on the motivation of the child. It's a good thing to use. It's not a bad thing to use. It doesn't do any harm.
That helps in positive reinforcement. That I think is a good way rather than negative approach. In fact, any child with voiding dysfunction or nocturnal enuresis should never be reprimanded for the same, because what we have to understand that no child voluntarily wants to bedwet or voluntarily wants to have a voiding dysfunction.
Absolutely.
So with this psychological aspect in mind, I think the positive reinforcement, praising the child for small efforts is what is going to be more beneficial, both in terms of the disease and psychology of the child. So yes, star chart is beneficial, is what I would say. So what is the most effective modality for therapy of nocturnal enuresis?
So if you want me to answer that, I'll tell you that, of course, Desmopressin is shown to have the best results, along with, if you can do a little bit of behavioral as well, if you can. Although it says the wet alarm plus Desmopressin works the best. I think wet alarms are not so easily available in India as such, So I would use behavioral therapy with Desmopressin as the most effective way of treating a child with bedwetting.
So a quick question for Dr. Satya Prasad. When would you do an MCUG and DMSA in a child with voiding dysfunction?
Any child with any child with recurrent infections, symptomatic UTI, and the child is having any abnormality in the ultrasound, if child is having bladder wall thickening or hydroureter nephrosis, that is an indication to do MCUG. And if child is having reflux, secondary reflux, usually they'll have voiding dysfunction, then definitely we should do DMSA scan also. If child is not having any abnormality in the ultrasound, then we can wait. We have to look for other possibilities like bowel bladder dysfunction, which we have to treat effectively. If you treat that, obviously, we can avoid recurrent infections. But any child with abnormalities in ultrasound, obviously we should do MCUG followed by DMSA if MCUG is showing reflux.
The DMSA also useful to see scarring on the kidneys, especially if you have reflux. Obviously,
sometimes
DMSA adds value that way, I think, a little bit more. You can also
even sometimes now
on ultrasound, a smart sonologist also will pick up, some depressions here and there, and looking at the outline of the kidney. But I think DMSA gives you a little bit more better picture if you want to do that.
Another thing is sometimes we might miss reflux also in MCUG. Any child, even though MCUG is looking normal, if child is having a recurrent infection, then obviously it's better to do DMSA to look for any scarring. If child is having scarring, it might be missed reflux. So obviously we have to recheck whether we have missed or not. Further, sometimes we have to do repeat MCUG also.
So in fact, in the follow-up, sometimes You can also do a renogram, isotope renogram using either DTPA or DMSA to look for reflux. Sometimes if you're able to do that on the table and keep your camera active, then you can even pick up the reflux on one of these isotope studies.
Yeah, indirect voiding cystogram, we can do that.
Exactly. Characterization of the child,
Exactly. Yeah.
And irrespective if the child is having recurrent UTIs, that's an indication to do the DMSA and the MCUG as per the guidelines.
That depends upon the age again. That depends upon the age. If child is less than 1 year, symptomatic UTI, then yes, we should do both MCUG and DMSA. Even MCUG is normal also, we should do DMSA. Because chances of scarring will be very high during first year, we should do both.
So neurogenic bladder and bowel, which one to start first? Should we tackle bowel constipation first before evaluating bladder? Should we evaluate and treat the bladder later? I think Dr. Shroff, you can take this question.
I think you need to look at both. You have to treat constipation definitely, because if you see the kind of the nerve supply to both is similar, and I don't think so. Obviously, that you can neglect one to the other, and you would have to address both the issues more or less together. Because if you don't address the bowel issues, obviously leads to constipation and soiling of clothes and so on. But the bladder issue is even greater, problem, because it leads to your renal dysfunction, and your creatinine will go up. So, obviously, you need to look at it simultaneously, and also you need to look at, what the presenting complaint more is. Normally, I think the child, the parents may complain more towards, the bowel more than the bladder sometimes, and then, and if you investigate the child and if you see the bowels are more of a prominent kind of problem, then of course you treat that. But if there's no difference, then you treat both.
Dr. Satya Prasad, for Hinman syndrome, would you do a urodynamic studies and MRI spine, both? Or
yeah, Hinman syndrome, usually this is like non-urogenic bladder. Here definitely we should do urodynamic study that gives information about this pressure, so that we can treat effectively with anticholinergics. And at the same time, if you are not conclusive, if you are suspecting some neurological issue, always is better to do MRI also. This is diagnosis by exclusion. If you are in doubt, it's better to do MRI spine also, along with urodynamic study.
I want to
because
add
you cannot miss even 1%.
If I may add a little bit to that, what Dr. Satya has said very nicely. Yeah. If you are able to do video urodynamics, that's ideal. Okay. In which you actually see, and if you're able to add an EMG to that, you'll see the sphincters kind of activity when the child is voiding. The sphincters are actually contracting, they're not opening up. So you'll appreciate that sphincter dyssynergia even more if you're able to do video urodynamics, which is sometimes not easy in a child to do, but it is possible. And if you're able to also put an EMG probe, then you really document it very well. That there is this dyssynergia. That can also add value to your investigations. But video urodynamics are not easily available because it requires a C-arm to be available in your suite.
Right. With this, we come to an end of the session. Thank you so much for this wonderful evening. Thank you once again, Dr. Kalai, for this platform, to IPNA and to the organizers. Thank you, Dr. Sunil Shroff and Dr. Satya Prasad, for being on board with us today. And I think the audience have got all their queries answered. And looking forward to more Webmaster series, Dr. Kalai. Thank you so much.
Thank you.
Thank you. Thank you very much.
Be safe.
Yeah, that's very important, to be safe in such times. Yeah. Safety first. Yeah. Thank you so much.
Thank you so much, sir. Bye-bye.
Thank you. Thank you.